All right, welcome everyone to the latest installment of what was formerly known as New Ideas in Insurance but has now been rebranded to the Insurance Law Workshop. I'm my amazing colleague, Peter Siegelman. And just a tiny bit of background on the workshop, if this is your first time joining us. So every other week, we get together virtually to discuss interesting papers and works in progress on the topic of insurance, very broadly construed. And so the goal is to bring together folks from different disciplines academics of different disciplines, practitioners, regulators, any person who's interested in the types of things that we're talking about, and yeah, just to sort of share ideas and gather to talk about interesting insurance topics. Just a quick note on format. So each session is about an hour long. We typically reserve about half an hour, maybe a little bit more, for the presenter to present, and then we reserve about half an hour for Q&A that's moderated by Peter or me. If you want to get on the queue, you can use the little raise hand function or send the chat to one of us. Just so you know, the sessions are recorded. The recordings are posted online. And I think that's it. We have a really nice lineup for this semester. I hope you all join us for all of them. We're really excited about it. And if I'm missing anything, I'll turn it over to Peter to introduce our speaker.
Great. So let me just say that today's paper is just very briefly about the history of private health insurance in the US and the road that it's not taken and might have been, where we might have had a very different system. I'll leave it to Professor Alsan to expose her theoretical and incredibly sophisticated empirical analysis. Let me just briefly introduce her and get out of the way. Our speaker is Marcella Alsan. She's the Angelopoulos Professor of Public Policy at Harvard's Kennedy School. It's relevant to the paper that she's both a doctor, MD, and a PhD in economics, and brings both of those skill sets to bear on this historical, empirical, theoretical, and fascinating piece of research. So welcome, and the floor is yours. Take it away.
All right, well, thank you so much. I'm honored and delighted to be here. This is joint work with Yusra and Xinyu, who are both graduate students. And this started off as actually research for a handbook chapter in a book on cultural economics, where we're trying to understand why different countries have not only do people behave differently vis-a-vis their healthcare, but why groups, institutions, and even countries have different healthcare systems, which led to this project. So a lot of this is probably well known, at least to individuals who are involved in health insurance on this call, that the U.S. is a bit of an outlier. We spend more on healthcare than any other country, roughly 1 out of every $5 of our GDP. And for a while, this was a bit of a conundrum. Is this because of P's or Q's? Was this higher prices or higher quantities? And the empirical literature has really come down and settled that it is indeed higher prices for roughly the same basket of goods. Now, the other Q, of course, is quality. So maybe it's this case that we're getting much higher quality than in other settings. But in fact, when we look at U.S. performance on a lot of different population health metrics, we might actually be surprised to find that our averages lag other high-income countries. And that's because of this vast heterogeneity that is seen across different groups in the U.S., either by class, by race, or by education or immigration. So there's a lot of different examples one could look to. I think this is top of mind, given the election cycle, is reproductive and maternal health. And here's some data from Commonwealth Foundation showing the U.S. Relative to other high-income countries. Again, we have a higher maternal mortality rate than our peer nations, but within the U.S., that's actually driven by several groups doing much, much worse, including non-Hispanic Black women, and those trends over time are actually quite worrying as they're going in the wrong direction. The U.S. is also different in terms of how we organize our healthcare system. in that the system is incredibly complex. So this is Uwe Reinhardt, who was a Princeton economist looking at the flow of funds between private households and providers of healthcare. You certainly have the government, state and federal government, but then you have a large presence of private employers and private health insurers. This value chain has become even more complex since 2011. Now we have other entities in this value chain, including things like PBM that just didn't exist before. So it's still the case that although we actually spend about as much publicly as a share of all healthcare spending, we actually spend about as much on a per capita basis, we spend about as much from a public sector standpoint than many other countries. Why we're so high is because we also spend quite a bit in terms of private dollars on healthcare, but it's still the case that most Americans are employed by private insurance. And despite the reforms, including the reforms of the Affordable Care Act, many Americans are uninsured, underinsured, or at least for some of the work that I've done in Oakland, California, and Flint, Michigan, a lot of people, if you ask them who are lower income, they actually don't even really know what their coverage is. We've seen this a lot on surveys where they'll list Medicaid and then they'll list Medicare, or they don't know that Medi-Cal is Medicare, Medicaid, and just exactly what they're covered for. So that complexity can be a real issue, again, for a more vulnerable group. What's been interesting to me, sitting as an MD PhD economist, is just to see how economists have kind of shifted the frame from thinking about, what are the different rules and how can we kind of exploit them, for example, to draw a causal inference on this thing or another thing, to really taking a step back and asking, what is the system of healthcare in this country, and what is this the optimal way to design a health system? And so they've been doing this in different sort of non-standard academic spaces, so not necessarily empirical articles, but more of books or review essays or things like that, and really calling attention to kind of how this very complex system really isn't necessarily delivering optimally, both in terms of efficiency or in terms of equity. So this project actually steps back from all of that and says, well, how did we get here in the first place? Where we rely so heavily on the private sector, but also have a huge role for subsidies and direct government insurance through, for example, fee-for-service Medicare. So Chase and Deaton are two, again, very prominent economists in Princeton who, in their books, talk about it as being a historical accident by which most Americans are covered through employers being a source of difficulty. Blue Cross Blue Shield of America talks about how in the post-World War II period, unions assumed very strong positions in their negotiations for employee benefits, and then employer tax exemptions for health and welfare contributions kind of furthered that movement along. In fact, I would say that is up to very recently, that would have been the leading explanation I would have had in my own slides. And you can see like New York Times articles kind of saying the same thing. And then Einav and Finkelstein, who are very, very prominent health economists, one at Stanford and one at MIT, in their book, which is a really delight to read, We've Got You Covered, talks about this popular narrative, the US never had a chance at achieving universal coverage. We lacked the labor movement strong enough to push for it, so kind of in contradistinction to what Blue Cross Blue Shield say. There was strong opposition from the AMA, the American Medical Association, and then there's just this cultural factor, going back to this chapter we were writing, of rugged individualism. So I did what the kids did and asked ChatGPT, right? We have private health insurance in the United States, and it talked a lot about, the strong tradition of individualism, the resistance to government interventions, and sort of so on and so forth. So very kind of similar to this cultural. So what we actually do is, and this is the rationale for the title of this project, we explore to what extent this interest group, the AMA, contracting with the very first political public relations firm in the history that we are aware of, Whitaker and Baxter, launched this campaign to defeat a key component of social insurance in the post-World War II era. They did so by focusing on indirect lobbying. So many of you are probably familiar with lobbying, quid pro quos directly to policymakers. This was actually really trying to go straight to the voter, and so indirectly get to the policymaker by influencing voter preferences. And how did they do that? This is the third I, through ideology. So they really framed this question about national health insurance that Truman had espoused, not in terms of, whether or not maybe the budgetary explanations or the health components, but really as a fight between, communism and socialism and freedom and democratic values. So that's really the bulk of the argument and the bulk of the advertising, as we'll see. But in addition, they didn't just sort of try and disparage the government public option. They also provided a private alternative that would persist, and that private alternative was in fact medical and state medical associations providing their own health insurance product, and doctors really serving as a vehicle to help sign people up through what today we know as Blue Shield. And that was known as private or voluntary back in the day health insurance. And their goal was really not just to defeat legislative efforts for public health insurance in the short term, but also to reduce demand in the long term. So if you haven't seen this photograph before, this is Whitaker and Baxter. They were a husband and wife team. They ran their PR firm known as Campaign Inc. And this is them outlining their battle plan in front of the AMA, their annual conference, saying the immediate objective is the defeat of the compulsory or national health insurance program in Congress. And there is great urgency in that phase of the problem. But the long-term objective is to put a permanent stop to the agitation for compulsory health insurance. And the most vital step in achieving that objective will be an all-out campaign to enroll the American people in voluntary or private health insurance system. So really what makes this project possible is that this team, Whitaker and Baxter, were incredibly meticulous. They kept very careful records. I'm a member of the AMA and have been for decades. I was a member of the American Medical Student Association. But visiting the AMA archives, you would just see pretty much a hole in this post-World War II period. There's just not a lot, and there's no mention at all of Whitaker and Baxter. However, the firm itself kept very detailed archives, very detailed receipts, their advertising intentions, invoices. We'll see some of those data, and their entire campaign strategy. And that was because this was a private company. They never went public, and they handed over the company to their son, Clem Whitaker Jr., who eventually, after his parents passed away, decided not to run the company anymore and gave the entire hundreds of boxes of firm archives to the state of California. So pretty much all of these data a lot of them anyway, are from Sacramento, many visits to Sacramento. And then through new techniques of machine learning and optical character recognition that has gotten much faster and much more streamlined, it really allows you to unlock text at scale and use these in the quantitative analysis. So we are able to combine these archival resources with these new technologies in order to develop a measure of exposure to this AMA Whitaker Baxter campaign in the post-World II period. We leverage what we find in the archive, which tells us they leveraged their existing AMA network as well as long-standing advertising relationships that Whitaker and Baxter had cultivated. And then we use something called event studies, which are sort of pre-post that vary along the margin of intensity to estimate the effect of this campaign on the number one thing, of course, being private health insurance enrollment, public opinion, which we get from Gallup survey data, and then political outcomes. Okay, maybe in the interest of time, I'll just skip some of these on the related literature and tell you a little bit about where our contribution lies. Where we think our contribution lies is that, if you think about this, from the standpoint of economists, we often talk about, what does advertising do in general? Does it inform people or does it persuade people to purchase things they don't need? But all the activity and all of the energy is really on products. Now we're talking about policy, advertising certain policies. I've already mentioned the distinction between direct and indirect lobbying. There is some really interesting literature about like why America is so individualistic, the role of the frontier, et cetera. But this is a different narrative. This is about how that individualistic, rugged culture was sort of leveraged and used to sell a policy. And then we think about not only how licensing, for insurance, for actuaries, for lawyers, and obviously for physicians, how that can reduce the supply and increase the quality. But it can also create these, it can also generate rents for whoever is now part of that qualified body, and those rents can be used then to influence the policy itself and further their market power. Okay, so let me tell you a little bit about the history of this situation, what health insurance was like prior to World War II, what about political public relations, and a little bit about the campaign before getting to the results. And I'll be very mindful of the fact that we want to leave ample time for Q&A. So you probably know much of this already, that of course World War II, prior to World War II, there were very few health insurance options. And that's true not just in the United States, it's kind of true worldwide. The UK had experimented with some sort of panel approaches, panel patients, and so on and so forth. But in general, it was really limited to life and accident insurance. So Aetna, MetLife, Prudential, those were all around, selling really to blue collar workers. And so the saying goes, nobody wanted a pauper burial, and these were products that were available to them to prevent that from happening. Now, in the progressive era, there was an attempt by Theodore Roosevelt and others of the time to think about a national health insurance plan. It would have been really one of the first in the world, and it made the error of including burial costs, so they encountered a lot of resistance from Aetna, MetLife, and Prudential at the time, and progressives were thwarted. And there were also questions about just the constitutionality, I should say, of doing something at the federal versus the state level. Now, of course, there was a massive economic shock in the form of the Great Depression, which obliterated incomes, especially for the elderly. And then this idea of, okay, what's the goal of government? Not just to provide a national defense, but also social insurance for people in these post-industrial times where they're not as tethered to their families anymore. And so FDR, when he was introducing old age security insurance, thought about, there were definitely attempts in his government to think about adding health insurance to that as well. But for various reasons, which in a longer talk we could go into, he demurred at that time. But as of 1945, and of course World War II broke out, but as World War II was kind of winding down, he actually put out, a second economic Bill of Rights in which he actually said everyone should have a right to medical care, and seemed like he was ready to now complete the Social Security Act with healthcare involved. However, he died very suddenly after winning a fourth term, and then this kind of dark horse, Harry Truman, ascends after just a few months in office as vice president, and reveals himself to be a very, very ardent supporter of national health insurance, but is quickly the Congress quickly flipped to Republican, and he can't really do anything about passing legislation for that. Then in 1948, there is this huge shock. No one thought that Truman would win, but he did. The famous paper headline shows that it was quite the shock that Truman actually ascended to the presidency. He ascended to the presidency alongside a commanding Democratic majority. And so now this is an Armageddon moment, because he's revealed vis-a-vis the AMA, because he's revealed himself to actually want to to push this policy forward, and the doctors are vehemently against it. What about political public relations? This is this Whitaker and Baxter firm. They had a bunch of different assets going for them. Whitaker was a former editor, had lots of connections to both Hollywood and to advertising. Baxter was actually she was part of the Chamber of Commerce, had a lot of deep business connections, and they grew out of California, which was direct democracy, had a lot of referendum and propositions, and so it allowed them to really practice at the state level at shaping public opinion. And one of their one of their really big wins was defeating Governor Earl Warren's attempts at passing state-sponsored health insurance. So again, there was a question, especially after the first attempts during the progressive era of a federal program were defeated, demand should devolve. The agitation still continued. It went to the state level. California, Earl Warren tried to pass health insurance there multiple times, but the California Medical Association had actually hired Whitaker and Baxter to help defeat it. And the first time, I think they were defeated by one vote, and then the margin kept getting larger. And Whitaker and Baxter took credit for defeating Earl Warren. They were very proud of that, and they advertised to other state medical associations, including the AMA. Now, one question I get asked by economists is, well, why would doctors even oppose this? This would have been a steady stream of income for them if the government is willing to foot the bill. We know how much doctors in the AMA in particular get, very exercised over the reimbursement rates for traditional Medicare. So why wouldn't they have just seen this as an opportunity to get, to de-risk their salaries? And in fact, the truth is doctors were for national health insurance before they were against it. But what seemed to happen over the course of the interwar period and after World War II, the medical profession became much more specialized. So you can see that, let me just go to this one first. You can see that the AMA is becoming incredibly powerful over this time period. That's the blue line. Almost 70% of all physicians are part of the American Medical Association at the time that Truman is trying to get some of this legislation passed. Today, that number is about 15%. So a lot of power. And at the same time, specialists are taking off. So this is going from 10% to 30% of the physician workforce. And these two trends are related. So the AMA is becoming more powerful as the technologies that came out of, many of them that came out of the war, mean that in order to, be a good a good radiologist, you have to basically just do that thing, and that brings higher return to their labor and much higher income. You can see their income of specialists are actually much higher than generalists. So this was a new fact that we found in the data. We thought this specialist generalist divide in salaries was new. But it's not. It's actually going back at least 75 years now, and then it's much higher than the average family. So these folks were not as tied to the AMA, and actually their incomes were very subject to the same financial risk that the average American family would be, and so these folks, generalists, would have been more in favor of national health insurance, but specialists were decidedly not. And you can see the income growth of physicians over this time period as medicine is getting more complicated and more specialized. And you can see even in who is becoming a president of the AMA, it's much more likely to be a specialist than a generalist. So all this to say that at the time that Truman is trying to introduce this plan, the AMA has changed from the organization it was even decades ago, with people that have much higher income, much higher prestige, and really don't have to bargain. There's no need for them to bargain. They have a lot of resources in which to fight the government as opposed to come to the table. So this is what they use their resources for. This is the AMA's national education campaign with Whitaker and Baxter as directors. It had two major components. The physicians were the field agents, if you will. like knocking on doors, but this was instead whenever you came to see your doctor, they would tell you to purchase health insurance or what were you doing for budget basis medicine. And then they had a newspaper ad mass communications component. So we were able to find the pamphlets that the doctors gave out to their patients. You can see there's not a lot of information on, what's covered or what's not covered. It's really this ideology, this, large, sort of angry looking American eagle, compulsory health insurance, politically controlled medicine, a threat to health, a threat to freedom, a message from your doctor. If you value your liberty, if you value the health of your family, turn inside and read this documented indictment of socialized medicine. So that's the type of language they were using. We can see it in a word cloud. Certainly the top 5 words are highlighted in red. You can see that there is medicine and health and insurance, but also compulsory, America, politics, government, freedom is in the background. You can see all of that is really coming to bear. They also did something very interesting, because we often think about the strength of local civic organizations and how that really affects the will of the people, your Kiwanis Club, your Veterans of Foreign Wars, etc. They, again, doctors being kind of prominent individuals, they did specific outreach from local, county, and state medical associations to those civic organizations, giving them template resolutions to pass and then send those on to their legislators in Congress. So this was a very, very directed campaign, and we've traced those resolutions all the way back to the National Archives in DC, and we can find them there. Second component was this large ad campaign. So they took out a huge ad. It was a full page ad, which actually, again, you won't find quite a lot about insurance, but you'll find a lot about, again, what's the American way, who runs this country. Men and women are finding the answer, voluntary plans, sponsored by doctors and insurance companies. This is the way to do it. So for more information, talk to your doctor or your insurance man. When we look at the word cloud, what was very new, and Vanessa, I'm not sure if you can see her sitting in the back, we have the invoices to see where these ads were taken out. But what Vanessa found was that she said, Dr. Alsan, I'm finding more than one ad per newspaper. And I said, Vanessa, there's only one ad per newspaper. We have the receipts. We know exactly how they did this. But what we didn't realize until Vanessa found it was that all of these other industries had been tapped by the AMA to also do tie-in advertising or coordinated advertising on the same topic. So here's Walgreens, very near in the product space, talking about, free America has no place for a bureaucracy that stands between people and progress, between doctor and patient, between physician and pharmacist. Free America has no place for socialized medicine. And then you can see the tagline, the voluntary way is the American way. Banks, farming, implements, all across the board, we find these tie-in acts that are really very subtly changing the narrative and affecting the consumer, the citizen, voter, however you want to call it. We can see that they're highly coordinated. So where there's one of those main large ads, you see a lot more of these tie-in ads. You see about 3 of these tie-in ads per newspaper. And when you put all of this together, let me see if now this is the campaign and the tie-in ads all together. Before, when we were looking at the pamphlets, you actually saw health and medicine. Health was a bit bigger. Now you see America is the largest and most prominent word in all of this advertising. America, freedom, voluntary, and medical and health are there, but they're actually a bit smaller than just the word America or freedom. So that was the new find. We were pretty excited to see that that's what was happening. Okay, now I realize that I have a lot more slides to go through, and I'm already at a half hour. So let me ask if is it okay to do maybe 7 more minutes before going to Q&A?
Of course.
Okay, great. So we're building this we're trying to build this exposure variable, right, that captures the campaign, that captures what the doctors are doing and what the advertising is doing. We're also going to take into account other factors that obviously influence the demand for any private good, especially insurance. So income, this incomes are rising in the post-World War II period. That would increase demand for any normal good. Unionization, you saw the Blue Cross Blue Shield quote. This is the story, the standard story about why we have so much employer-sponsored insurance. We take into account the growth of hospitals. We take into account time variation just because maybe technology is improving. And so the value of medical care is increasing over time, et cetera, et cetera. For those who are interested in this period, it's very kind of neat to look at what the legislative part of this, enabling legislation. So, part of what happened too was that these were considered nonprofits, right? That they were able to start their insurance product with very, very little capital because they had successfully obtained from attorney generals and through state legislators, quote unquote, enabling legislation. So a special set of rules that allowed them to start these products kind of really with very, very little in the terms of resources. If you also want to look at these products, we've been able to look at all the plans, and you can see that they tended to not cover pregnant women, not cover children. These are where things like you can see enrollment windows start to appear to get rid of risk. Adverse selection is first used, I think, with respect to pregnant women. So you can sort of see these things kind of developing in real time in response to now selection and, of course, adverse selection. Okay, so in a longer talk, I would tell you about all of the data elements. Because I've teased it, I'll just show you that this is the type of detail that are in those Sacramento archives, literally the invoices of the advertising company that tell us exactly where they put these ads. We can also look at, for example, I already showed you the pamphlet. This is the information we have on the outcome. So these are these voluntary insurance plans. So we were able to find in the libraries and also at the AMA archives and in various different places, annual books that were published on these medical society plans. And this is what gives us the detail about who was covered and how many were enrolled and who was excluded, et cetera. So that was kind of neat. And then the Gallup data have lots of different questions that we can use here. But there's one thing I always tell the students when you look at the Gallup data is you want to be careful because the questions are asked in different ways. And we can actually see when this campaign started in around the end of 1948 up to 1950, you can see that the types of the ways in which Gallup even asks the question changes. So it starts by asking about national health insurance and public health insurance, but by 1949, they're using terms like compulsory or state compulsory insurance more and more often. So they're kind of adopting the language of the campaign in some ways, which is very interesting in and of itself, how the questions are asked. I already told you about the resolutions. The last thing I would say is that we can find even after we can find evidence of one of the very earliest acts. It's not the very first one, but in 1952, when Eisenhower was running with Nixon, in fact, the Whitaker and Baxter and the former AMA president started at what they called the National Professional Campaign for Eisenhower, and we were able to find lines like this of every single physician that donated and the amount. And so we can link that back to exposure to the campaign as well. Okay. I know I'm running out of time. I will skip the theory and I will just go right to the results because we don't have time for the theory. So this is just our exposure, and we're going to include things like state fixed effects and year fixed effects to draw out anything that might be different from different states or from, take out just secular trends. And we're going to include our controls, things like insurance and unionization and things like that. A similar equation for public perception. For civic organizations, again, we're going to relate campaign exposure to the number of civic organizations that are passing resolutions in support of the in support of voluntary health insurance, private health insurance, and against national health insurance. And then we won't have time for that. So this is basically the key result here. This is looking prior to the campaign. This is during the campaign, and this is after the campaign. And what we're looking here is the share enrolled in private health insurance. You can see that it's very, very low up until the time the campaign starts. And then we see that the share enrolled, this is across the entire population, is about 3% per annum. And in 1954, one of the reasons we stopped then is because that's when the tax code actually changes. And that's when there's a massive advantage now to actually, because it's tax exempt, any employer and employee contributions to private health insurance. And then we see the market really become flooded with private insurers, and these Blue Cross Blue Shield entities start to get, a smaller and smaller part of the market. They're really getting not enough of the market at that point. But so this is the effect of the campaign on insurance enrollment. We can see that the campaign exposure doesn't affect things like personal income or unionization, so it can't be something like that that's going on. We don't see the same trend there. And so all in all, we see anywhere from a 2 to a 2.5 percentage point increase in health insurance on average per year across the entire population in response to this campaign. That's about off of a base of 3 percentage points. That's about 75% of the total. And of course, it's because we're denominating by the entire population. These numbers are 2%. If we denominated something like the white employed population, the numbers are much, much higher. And that's probably more accurate because these products were not available to everyone, especially initially. To show you one other thing, this is what we see for public opinion. In fact, public opinion for national health insurance was very, very high prior to the campaign. About 70% of Americans supported it, but after the campaign, we can see this precipitous drop. And that's this is the table form of this. It dropped, again, it was about 70% in the pre-campaign period. It dropped anywhere between 6 and 8 percentage points per wave in response to the campaign exposure. We can see who was affected by this the most. And actually, individuals who had previously voted Republican seemed to be the most receptive, but also were urban dwellers. That could be because they had more access to hospitals and these specialist doctors to begin with, and therefore were more intensely treated. You can see a positive relationship between campaign exposure and the number of civic organizations in your area that are writing these resolutions supporting private health insurance, about 2% per standard deviation increase in the exposure variable. And then I think this is the last result I'll show you so that we have time for questions. Then we actually looked, this never came to a vote. As you're probably all aware, the Truman Plan never came to a full congressional vote. So in that setting, how can you even say that this had any effect on anything when it never really came to a vote? So what we're able to do, though, is to trace just the way it affected the way people were speaking. And so here what we do is we see the campaign did not affect either whether or not a legislator, this is now a data set of legislator quotes. So we've taken the entire congressional record and digitized it for the 81st Congress, right? Well, actually that was already OCR, but it still took quite a bit of processing because nobody had done the appendices, so we did the appendices too. But you don't see mentions of health insurance being affected by the campaign. You don't even really see mentions of the AMA being affected by the campaign, but you do notice right off the bat that Democratic legislators are talking about the AMA in a pretty frustrated tone, I should add, more than their Republican colleagues. What we do see is conditional on the legislator talking about health insurance at all, they use the term political medicine much more if they're a Republican versus a Democrat. So more exposure to the campaign increases the way in which health insurance is talked about by Republicans versus Democrats. And these differences here in this column here are statistically significant at the less than 1% level. And then you do something called the cosine similarity. So this is like a vector version of comparing the way in which legislators are speaking to the way that the AMA Whitaker Baxter propaganda sound. You just do these cosine distances and in this large language model. And here you can see that more exposure to the campaign indeed makes Republicans sound more like the AMA and Whitaker Baxter. And again, these are going to be statistically different at the 1% level between the response Democrats have, who already sound less like the campaign propaganda than the Republicans at baseline. So those are very new results. Those were not in the paper before, so we're kind of excited to show you those. Let me just conclude. I'll just put my conclusion slide up. Sorry to keep you a little bit busy here. But yeah, we find that this campaign, organized by a political PR firm, Whitaker Baxter, funded by the AMA, with those rents that they were getting from the increases in technology and the marginal product of labor, especially for specialists increasing, they took those rents, funneled them into this large-scale campaign using ideology to sell a private product. They enjoyed a lot of synergy and a lot of coordination with other groups like the National Association of Manufacturers. It caused a shift in public opinion away from national health insurance. It caused an increase in private health insurance. And I think it's fair to say that Whitaker and Baxter may have indeed achieved their objectives. They defeated, in fact, didn't even really come out of committee, the legislation in Congress, and now we have a private option that has very much persisted. Thank you.
Wow. I don't even know where to begin. Thank you. That was an unbelievable amount of work. And for the non-empiricists in the audience, like, there's so much going on behind the scenes that these guys did. That's just like, well, we just coded an entire year of the congressional record. So anyway, there's lots of questions. I would love to talk with you for another couple of hours, but I don't want to monopolize things. Here's maybe a big thing, one, and maybe you can just duck if you think this is too big. But the basic idea of democracy is that political institutions are supposed to respond to the prior beliefs of the public. And it seems like in a world where the prior beliefs of the public are not prior, they're endogenous because they can be shaped by actors. It's not just like, well, the AMA influences legislators. It actually, if you're right, it seems like you are, they're actually changing what the public actually thinks. So then, like, what does democracy even mean in that kind of a context where, my preferences are just a function of what somebody tells me they should be?
I think that's what's, here at the Kennedy School, we have a lot of international students, and I always kind of understood propaganda, and I felt like I really, really understood propaganda as what the state, for example, the Chinese Communist Party has a whole propaganda, department, Minister of Communications, right, or Minister of Information. What I started to think about, and this is obviously overly simplistic, but I started to think about it in this Cartesian system of like, we're all exposed to propaganda. It's just, is it coming from the private sector or is it coming from the public sector? And what makes me feel very empathetic for individuals is, like, literally we didn't even understand what we were looking at. And here it's 75 years later, how could the average, white middle class newspaper reader going to their doctor, living their life, how could they have ever known that they were part of this really large scale, very coordinated and well-funded campaign? It would have been so hard for them to even, I don't know that they could have ever known that. So that was one thing that changed my view about, like, the nature of propaganda and whether it's just something that, is kind of a problem far away.
Yeah. Okay. Travis, did you want to come in? There's a couple other people on the queue, but please feel free.
Well, so this may take you a little bit far afield from this particular piece of research, but impressionistically, like looking at the ads that you put up on the screen and in the paper, it seems like the rhetoric at the time, was focusing on freedom, choice versus like politics, but that the war over the need for or the propriety of public insurance continues. It seems like the rhetoric has changed over time, and correct me if I'm just misreading what you're putting up, but like today it seems like the rhetoric is more about like kind of distributional, like it's framed in terms of like kind of moral hazard, adverse selection, like cross subsidy logic, rather than freedom. And I guess is that an accurate understanding of or do you think that's an accurate description of a shift in kind of logic or rhetoric, or is that just more a change in emphasis?
I was surprised at how, especially now looking back at the debate over Obamacare or the ACA, like literally, I think Suzanne Sanders, who I just knew as like, I think that's her name. She's in Three's Company, but she had a Wall Street Journal op-ed against Obamacare, and she had one of the quotes that she quoted was directly from this campaign, saying that a national, a compulsory health insurance is the cornerstone of the socialist state, which was, attributed supposedly to Lenin. Nobody's ever been able to find Lenin saying that. Apparently, someone scoured the congressional library and couldn't find that quote. But that was like the exact same quote. John Gruber, who is an economist at MIT and sort of one of the architects of the ACA, he developed this like cartoon to explain it to American voters. And in it, he has somebody saying, but isn't this going to lead us to socialism? And isn't this going to be, so I think there is some stickiness to this idea that it's sort of like a slippery slope. And yes, there's a lot of cognitive dissonance, because if anybody looks at their pay stub, they'll see that they're already paying for payroll tax, for, social insurance for old age and for Medicare and things like that. And that we have massive subsidies going out all the time to provide insurance, including for healthcare. So I do feel like there is part of the ideological argument, and the ideology was essentially, and I don't want to neglect talking about the racial component of all of this. Like the ideology was very much like, am I my brother's keeper? Are we going to care about everyone? Or is this about individual freedom, individual choice, et cetera? So there was that tension kind of way back there, way back when. And so the distributional concern, one of the cartoons that the government had was like, yeah, you'll get some people covered, but you'll leave so many people uncovered. And they had like a blanket that was not covering all of America. So that also feels a bit familiar to the equity considerations that we might have today.
Okay, so I had Kira next and then Larry.
Yeah, hi, thank you. I guess my question is kind of putting this in perspective for someone who doesn't, know so much about medicine or the opinions of doctors. Like, I guess my question is, like, do you think that the AMA and the specialists that were running it were correct about their concerns? Has this affected like the ability of the salaries, I guess, of specialized doctors, or has this kind of, because I know there are a lot of doctors today that, even some more specialized ones that do make a lot of money through some of these government programs. So I guess I was trying to see, like, was the AMA off base? Were they right even in this limited way? And what your thoughts were on that?
Yeah, I think it's a great question. These are all great questions. I think it's easy to kind of villainize even today, interest groups, or especially the AMA. I mean, what's shocking to me as a physician, I didn't know this at all. But I mean, there was a true sense that they wanted professional autonomy, and they felt that that was going to be encroached upon. That was mixed in with the fact that they wanted to set their own prices. You know, who doesn't? Who doesn't want to set my own price? So there was this, there was both of those motivations. I think were very prominent in their push for this campaign, which became all the more fervent when the UK, who is of course our our colonial our colonial forefather, and also very close to us in terms of institutional features, and also an English-speaking country, had the NHS and instituted. And so that also scared them a lot, because the British Medical Association had also fought against the nationalization of healthcare in that country. I will say this: I do not think that the doctors knew that this would all become, that they would lose control. And I think most doctors today say they have lost control. They don't have the autonomy that they thought they would enjoy under the system they thought they had. As soon as the 1954 tax law, even before, but it was accelerated dramatically with the change in the tax code, private entities came in, and now the rest is kind of really history. Now I think doctors really feel like now they're trying to unionize in order to wrest back some of the power from these other kind of profit maximizing forces that are familiar. Susan Summers, thank you.
Let's see, and Larry, be back.
Yeah, I had a couple, but kind of following up on Kira, why do you think a national health care system is better than what we have now? If I look at the unpopularity of the NHS in Britain, and you look at the innovation the U.S. healthcare has delivered worldwide, if I'm getting cancer, I'm going to MD Anderson or Mayo Clinic. Why do you think it's inherently better to have a national healthcare system than what we have now, which is kind of a combo of public and private with Medicare and the ACA?
Well, thank you so much for that question, Larry. This is really not a normative paper. This is, a positive paper. This is trying to understand why we don't have that system, why we have the system we have today, what system we should have. I think that, really goes beyond what we can say here. But if you've ever had the question of why we look so different and some of the consequences of that are distributional, then I think this is a paper that can try and speak to that.
Okay, well, one reason why we have the system we have is because the private system is better, and it's not manipulation. So, so I don't know where that line between what the difference really is. I mean, it seems like the paper is, explaining, kind of this massive manipulation of the public, which may be true, but the flip side is maybe they weren't manipulated. They were just doing what they felt was the best for them.
Unfortunately, I can't speak to that hypothesis.
Yeah.
That's a hypothesis that we are able to identify the effects of this particular campaign, which did resonate with some individuals, especially those who had voted Republican in the past, more so than others.
Thank you.
Yeah.
Anybody else? We have a couple more minutes. Can I come back in with just a question about the magnitude? So it seems like you said, I think I remember right, that you said that they spent $19 million, which is like 240 million in today's money, but they generated a 70% increase in the number of people enrolled in private health insurance. I mean, like you said, 6%, I forget the percentage points, but something like it went from 3% to 5% or something like that. So that's like the biggest return on investment in the history of the world, without even baking in like the trajectory that you put people on. So you really move things that much with that little money. Does that surprise you at all, that things are so malleable?
So I think there is an entire sort of literature on what are the returns to advertising, and it actually is a very difficult question empirically to answer, because typically you need to have this massively powered studies in order to do that. And any one sort of marketing campaign has a lot of heterogeneous returns, and it's difficult to come up with an average unless you're targeting it really well, which is hard to do on a massive scale. In any event, setting that aside, I've done a lot of work just looking at physicians themselves and like looking at, for example, which types of physicians are best to try and improve the take-up of preventative care. Or in the beginning of the COVID campaign, when we didn't have a lot of sort of messaging going out, myself and a group of other economists and physicians did a lot of work with Facebook to try and get some messaging out using physicians to talk about, for example, holiday travel and things like that. And those campaigns actually, and those experiments have been really effective. So what we kind of, putting those two things together, I think what I take away from it is like, this is a fairly new product, health insurance, not a lot of priors. People were, likely to trust physicians who they thought were authorities on this particular topic. And the physicians were, for the most part, able to use not only the office or their office visits to try and talk to people directly about the use, the need for a budget-based medical care and this particular service, but they also then use their kind of prominent role in society more generally to outreach to these civic organizations and work with them, and also had their wives involved and things like that. So I think that's what helps make the return on an investment so strong. And also kind of coming back to Larry's point, thinking about this time period, we had just come off a series of price controls in this country in order to try and stem inflation related to the war. And so they were also able to use their network of many other industries. Again, physicians being prominent, they took care of business leaders all over the country. And we're able to make this very compelling argument that said, if the government sets prices for us, they'll set prices for you next. And that really resonated with many of these other industries and helped scale the advertising quite a bit.
Okay, well, I don't see any other hands, and it's just 5 o'clock, so please join me in thanking Professor Alsan for that fascinating talk and the great paper. Really appreciate your coming. Thank you.
Thank you so much. Take care, everyone. Have a nice week.
Okay, bye, thanks. Come back and see us again when you have another one.
Okay, will do.
Okay, bye.